Okay, I think it's a great time to start. So we're going to get started with the folks from Nurture Connection. We are thrilled that they can be with us today to share the great work that they are doing, and we're happy to have you with us as well to learn more about early relational health and how you could be a part of that movement. So I'm going to turn it over now to David Willis, and he will be your guide throughout the rest of the webinar. Thanks for being here today.
Yes, thanks, Michelle. Hello, everybody. Welcome. We're excited to share with you the work that we've been doing over the last few years about advancing early relational health, and specifically our Nurture Connection network. And we're eager to share with you the journey we are having and invite you from the good work that you've been doing to think with us about how the early relational health and the Nurture Connection work can be meaningful for you. So if we could put up the first slide, today we're going to have, next slide, a conversation with some of my colleagues. Claudia Risti is one of our parent leaders with our Family Network Collaborative. Dana Long is a pediatrician at Benioff Children's in Oakland. They'll talk about early relational health in the health sector. Allison Logan is a system leader in Bridgeport, Connecticut. That'll talk about ERH and action in the community. And then we're going to have a conversation together and then open it up for questions and comments from you all. So we're really thrilled to be able to share this good work with you and your take and your thoughts. Next slide. There's been a number of us that have been advancing the importance of early relational health. And we've, about a year and a half ago, created what we call Nurture Connection, which is an effort to create a national impact network that advances early relational health in partnership with families and communities to build thriving and development of all children, families, and communities. Our mission is to be in partnership with families and communities to promote early relational health for every family and every community by coordinating, catalyzing an active and engaged national network of organizations and individuals. Our vision is a future where every family experiences the joys and the benefits of strong, positive, and nurturing relationships, where every community and all systems support emotional connection between parents, caregivers, and their babies, and view that early relational health is vital to building a healthier community, healthier society. We define early relational health as the state of emotional well-being that grows from the positive emotional connection between young children and their caregivers when they experience strong, positive, nurturing relationships with each other. Early relational health is vital for creating the foundations of health, social emotional capacities, lifelong health and well-being, and connectedness. Next slide. We've learned about the importance of this work, and through Nurture Connection, we have come together and created our values that are about believing in a healthier future begins with thriving children. We believe in the power of connection. We value families and all of the various cultural wisdoms. We stand for equity and justice. We champion communities, and we believe that together we can work together to create change, thriving, and well-being and flourishing. Next slide. We believe that early relational health matters. It lays the foundation for healthy brain development that supports the well-being, learning, and behavior of all people into their adulthood. It creates the necessary footing for young children to optimally learn and engage the world around them. Early relational health helps children to cultivate relationships through their lifetime. And it's foundational for the well-being of both children and caregivers. And in that way is a two-way, bi-directional experience that generationally affects not only the well-being of caregivers, but also the well-being of children, and thereby has benefits in the moment and also benefits for the long term. Next slide. And we're guided by lived experiences with families. We've learned, as you all know, the importance of partnering, the importance of honoring the strengths and the wisdom and the values of partnering to the strengths of families And we've intentionally created, as you'll hear about, the Family Network Collaborative, which is a network of 6 parent leaders from across the United States that represent a diversity of communities, families, and children. These 6 parents engage with their network of 10 parents from their local communities that bring perspective, insights, and recommendations that are effectively a cohort of families 0 to 6, 66 parents that help guide, inform, respond, and co-develop all of our activities together. Next slide. Equity is our mandate. All relationships, caregivers and families, and their associated health and well-being certainly can be impacted by inequities in our society. And we know that social, racial, cultural, and economic injustices and those challenges can create obstacles for families and overload them, and thereby make it difficult for them to be in the strong relationships and the way they all wish to be for the strength of their children. Those overload and pressures make it difficult, and connectedness, as well as being mindful of the drivers that make it challenging, are all a part of what we value in nurture connection to advance early relational health. Next slide. And early relational health embodies equity. We celebrate the strengths and diversity, recognizing the importance of individuals and communities, their social, cultural, political, ecological, and spiritual identities. We know that relationships and powerful connectedness can buffer against adversity. Those positive childhood experiences can really help families bear the challenges in front of them, and those strong, positive, and nurturing relationships can provide buffering even in face of challenges. But we also know, why should we have to buffer? All things we should be doing should be building the strengths and supports that all family needs by addressing unjust systems, policies, and practices that make it difficult. Both the implicit biases and the challenges of policies and practices that perpetuate inequities and the unjust outcomes that we all know about. Next slide. Nurture Connection is really about bringing about meaningful change in a collaborative effort in an impact network. We share emerging knowledge and we amplify what are breakthroughs, what are innovations, what are the learnings, what are the collaborations that broaden the thinking and the learning about spreading activities that promote early relational health in communities, in neighborhoods, and also in policies and programs. We connect field leaders to each other, encouraging collaborative efforts, and thereby knowing that that collaboration is greater than the sum of each of the parts. And we support the engagement and the development of families as leaders in partnership in all of this work across this network and across these initiatives. Next slide. And we've embraced a shared leadership model. We launched Nurture Connection in February of last year, building on top of networks that we were generating across pediatrics, public health, infant early childhood mental health, community leaders, place-based agendas, and the like. And we created intentionally the structures that are a part of our Nurture Connection model. The Family Network Collaborative, you'll hear about more in a moment. We have a steering committee that is made up, including parents, of about 15 individuals across sectors that help guide this work moving forward. From that steering committee, we have a core planning team that is a part of the coordinating hub of advancing this impact network. And we've been growing a national leadership network of cross-sector leaders that are all contributing and guiding and developing their own efforts across the country in various communities, states, and tables to advance early relational health work, again, along this grand vision. Next slide. And we generated, after we did a field survey last year about how has our work of Nurture Connection, the website of resources and activities, and our ongoing monthly newsletter, our webinars, our bright spots, and our contributions, what does this mean to the field in its broadest sense? Who helped generate for us how we should think about our next year and a half to 2 years of work? And our goals of Nurture Connection for 24-25 are to continue to grow and sustain this network, broaden and connect with other networks, centering parent and community partnership in all things we grow and develop, broaden and spread the principles of early relational health and its importance in all family-facing and child-facing efforts together, and promoting the implementation and dissemination of best practices that are from strong evidence and also bringing meaningful change. And we're mindful of the policy landscape to advance early relational health as well as systems change. That's our broad agenda. And the people you're going to get to, my friends and my colleagues that you're going to hear from today, share with you how this work is how it's moving, what are the elements, and how we are moving this work forward, not only in health sector redesign and opportunities and innovative works, but also in system building efforts in communities and the like, all centered around the voice of families. So if we can go to the next
David?
slide. Yes.
I just want to point out, we have a couple of questions in the chat. They may be addressed later, but just so that people can have the answer now. Are there population level outcomes, short, intermediate, long-term, where communities can measure the success of early relational health efforts? Is the first question.
The population outcomes have not been specifically defined. We're mindful of the National Survey of Children's Well-being, the thriving indicators. We're also mindful of the developmental screening and developmental rates and the kindergarten readiness rates. We're mindful of measures that are already moving in that place, but we've not yet defined specific measures of early relational health itself. They're in development. And then participants, how are the parents selected? Through the networks of communities and people we were working with that were aware of networks where parent voices could be contributing. And maybe Christy, you might be able to speak to some of that. So let's go to the next slide. And Claudia, I wonder if you could talk about our family collaborative network and then how some of our parent leaders came together here. To you, Claudia.
Absolutely. Thank you, Dr. Willis. It's a pleasure to be here with all of you, being able to represent the Family Network Collaborative and the amazing work we have been doing as part of Nurture Connection. One of the really unique things that about this effort in network is the fact that the parent voice is at the center of everything that is done. And that has been something that is very unique and powerful. In another hat that I hold, I'm the director for the Reach Out and Read program at Bellevue Hospital. So when you were asking about how some of these parent leaders were selected, is in terms, one of the things that we wanted to make sure is that regionally we were representing different areas across the nation, also different sectors and different type of families. So I'm in New York, I'm based in New York. And if we go to the next slide, we will be able to see, the locations and geographically where we are all leading and talking to the families that then bring their voices into the work that we're doing for this amazing network. So we have a parent leader in Alabama representing families who live in the rural South, and someone in Michigan who has access and works with family who has benefited from the home visiting services and also identify as Black and Brown. New Mexico, in the San Felipe Pueblo, families who identify as Native Americans. I already say I'm in New York, and I represent families who are Spanish-speaking immigrants. In California, our parent leader represents family with a special health needs or disabilities. And in Washington, we have a dad who also represents other fathers and dads. So we bring all of our parents' unique voices. And what happens is that before let's say the research team has a question, they pose it to us, the parent leaders, and we go back to our parents and ask the questions. But before we ask the question, one of the interesting things for you to know, if we can move to the next slide, is that every single parent that we have represented is a parent of children of the ages of 0 to 3. You see it here, the demographics about also in terms of their economic background and the geographic location. And what we would do is, one of the things we realized early on in the process is that those questions that were being posed to us, we had to translate it into living room language in order to be able to capture the essence of the information that was relevant at that point. And one of the things that I enjoy the most about the whole process, it has been really humbling even for me. I've been working here in this pediatric clinic for 23 years. And if you had asked me before I started participating as part of the FNC, if I could tell you what the families thought and feelings were in regarding to a specific topics, I felt very confident that I could say that I could represent their voice. However, as part of this process, whenever I go and speak with the families, it has been very humbling to see that I still have a lot to learn. And that's why this model has been so wonderful, because it really puts their voices at the center. And the family have been really honored to see, and very surprised actually in the beginning to see that we wanted their opinion, we wanted their feedback. I had parents who said, why? Are you sure you want my opinion? Is that really valuable? Because they have been used to function in settings or in structures where their opinion and voice was not really considered that important. While here, everything is driven by the parents' experiences and the amazing richness that they're their experts, and we want to be able to highlight them as such and learn from them as we join forces as a network to be able to support the work, the amazing work that they're already doing. Right now, for example, we're asking of our parents, one of the questions was about equity. What does that mean to them? How have they experienced that? Because that's one of the core values. We want to be able to hear about their experiences, learn from their experiences, so that we are affecting change across the nation in a way that is meaningful for the intended audience, which is parents and families of very young children. And I know you're going to be hearing from some of the other colleagues today who are very well connected in representing some of the other areas of this amazing network. And I just say, personally, is something that I'm very proud of the work we do. Right before I joined this meeting, I was talking to a mom who is 20 weeks old, 20 weeks of gestation, I'm sorry. And we were talking about the importance of that connection, of that early connection with her baby, even before the baby is born. And by talking and reading and singing and touching, and how much that impacts the general overall development and health of the baby, but also of the family, and how each of the family members have an important role in setting up that foundation, which is so critical for the future of that baby. So it's a pleasure being here with you. And if you have any questions, I'll be happy to answer now, or I'll be happy to answer them as we continue hearing from the other colleagues.
Thank you, Claudia. You have great comments in the chat about how the focus on family voice is really inspiring. Hello, everyone. I'm Dana Long. I'm a primary care pediatrician out of UCSF Benioff Children's Hospital, Oakland. I also have been part of Nurture Connection since the establishment with Dr. Willis, and it's just been an incredible journey. And I'm very excited to share how the principles and practices that Dr. Willis referred to are being reflected in the clinical practice and the clinical transformative work on early relational health and health equity. Next slide. So I want to introduce you to a clinic that I founded this past summer, and I'm introducing you to this clinical transformation to be used and lifted up as really an example of what is possible when we focus on families, focus on relational health, and focus on 0 to 3-year-olds. I'm going to share our Bloom clinic. And Bloom stands for Black Love, Opportunity, and Outcome Improvement in Medicine. I was very glad to see the question about measurement and impact because I'm going to speak about that when I talk about our evaluation. So Bloom is really about reconstructing early childhood care for Black families through a racially concordant. By racially concordant, I mean that self-identified families, Black families, can actually have access to self-identified Black care teams that are really trauma-informed and multidisciplinary. Next slide. So quickly, I want to describe why we established a Bloom clinic, what is Bloom, how we are blooming, and then nourishing the ground to scale and expansion. This is one of my families you'll see in this picture, and what strikes me so much when I see this image of my patients and their caregiver is just the love, like the love and the devotion that they have with one another and this sense of protection. Next slide. Why we must bloom. I want to rephrase the statement to be why it is that we must explicitly focus on being pro-Black in the work that we do of focusing on health equity and early relational health. What we do know from statistics is that our Black babies are 2 to 3 times more likely to be born preterm or to die before their first birthday. We know from the maternal health literature that Black birthing people have the highest rate of infant mortality of any ethnic group in the United States and are 4 to 6 times more likely to die from pregnancy-related causes. There are also statistics that even when you control for social economic status and education, so myself as a mother of 3 Black sons, my risk of my child dying was higher than the risk of any white person who didn't have a high school education, right? And so figuring out why it is that we have such high rates of morbidity and mortality is really important, and being able to be solution driven in order to accelerate equity and reduce these disparities. What we also know from a scant amount of literature is that when Black babies are taken care of by Black providers, you actually are able to reduce those disparities. We see this tracking across the life course and fabulous studies that were done in barbershops, that when Black males are actually talking to Black patients around things like hypertension and diabetes, you actually can improve health outcomes. Next slide. So what we do know is the current system of care for Black families is often rooted in historical inequities and fragmented. And that translates down to our babies being exposed to increased parental stress, increased morbidity, increased rates of things like asthma, obesity, diabetes in the long term. They tend to have higher experiences of ACEs, which are adverse childhood experiences. And we know trauma really can get underneath the skin and lead to poor health. Next slide. All in all, the summation of what I just shared is that the current standard of care, particularly for our Black and Brown families, is unacceptable. And there's a strong desire to reconstruct pediatric primary care. The Bloom Clinic was really born out of the brilliance of our Black identified staff, co-created with our Black families. Next slide. Bloom is a call of action. It's a call of action from our community. It results from a lot of the historic wisdom and the guidance that we've had from our community members. It's born out of a desire to love and respect our community and understanding that there's so much strength and beauty in the Black community and that we want to be able to lift that up and dive in and wrap our arms around each other. Next slide. So our vision is that every Black child deserves to grow up valued, celebrated, healthy, and exceptional. And we are using this transformative moment of time to really redress the inequities and prioritize the health and wellness of Black children and families. Next slide. So our mission is to deliver excellent family-centered primary care that honors the experience of Black caregivers and their babies. I also recognize that my team, as Black staff and doctors, that we also have experienced immense amounts of current and historical trauma, and part of the focus of Bloom is healing the healers. We also understand that we have academic anchoring within the University of California, San Francisco, and our goal is to really balance scientific methods of discovery, but root them in equity and understand the role of racism in healthcare. We want to evaluate the model of racially concordant care and then scale the model. Next slide. So our Bloom Clinic offers racially concordant primary care for 0 to 3-year-olds. We do this through a number of modalities. We are able to pair Black pediatricians, Black doulas, therapists, community health workers, research coordinators, all working together to understand and address the priorities of each and every patient and family. Beyond our pediatric primary care model, which is what you typically think of when you come into a safety net clinic, the difference is that we currently have 3 Black providers. We have a therapist who has a long history of working in our neonatal intensive care unit, and we're flipping the idea of mental health and wellness on its head. And so we are not diagnostically driven. Just like I, as a pediatrician, go into every room to see families, I have co-visits with a therapist who goes into every room and says, "How are you doing today? How's your mental health? How are you feeling?" So that you don't have to have a diagnosis of anxiety or depression in order to see a therapist. It's just an expected part of primary care. My life has been changed as a result of working with a doula side by side. When I see a 5-day-old, what they really need is that loving, supportive, expert knowledge of our doulas in order to support feeding. The health benefits of breast milk for both the baby and the mom, and really just understanding and an ability to hold that family. And so our doula goes in and sees every single new patient with me and then follows up with the patients who would like to. We also have an amazing community health worker who is able to do resource referral and linkage around food insecurity, housing instability, activities for children, access to nature. I'm also really proud of our dyadic group visit models where we have Bloom with breast friends, and our breastfed groups are lactation groups for moms and babies. And we also now are launching, starting in July of 2024, Black joyful parenting groups to be able to talk about not only the great things about parenting, but sometimes the hard things, and to create social networks with our families. These joyful Black parenting groups are being run by our social worker and one of our pediatricians. Next slide. So the Bloom team firmly believes in the power that Bloom has to change the standard of pediatric care for Black families. And each and every one of us is so deeply committed to the work that we do. And in this slide, you'll see our nurse, one of our new faculty members who just graduated from residency. And I want to say how exceptional it is to have a queer identified Black male as a role model for our babies and their families. You see my clinical research coordinator, our manager, our community health worker, and myself. Next slide. So our key strategies are really focusing on the racial concordance, that every family will have access to a Black pediatrician and team. Our team-based multidisciplinary approach. We are focused on cultural humility and trauma-informed care, really being able to build out trusted, supportive, and healing relationships with each other and with our patients. We have a family lead who co-created clinic with us from the beginning. She is part of our leadership team. She also is part of our research and evaluation team. Everything gets run by her and then her families before we actually implement it clinically or in our evaluation. The staff wellness piece around healing the healers through art, mindfulness, reflective supervision, and celebration has been crucial. We meet with a therapist who is specialized in infant and early childhood mental health in order to make sure that we are as healthy as we can be so that we can show up for our families. Reflective supervision is not often a part of clinical practice from a medical perspective, and bringing in the infant child mental health specialists in order to help to support the team has allowed us to get through our days without being completely burned out and traumatized through vicarious trauma. And then something that's amazing that happened is the workforce development piece, where we're really cultivating future leaders. For the first time ever, as far as we know, we now have 13 Black identified residents in our program, and we really want to be able to support their journeys so that they can graduate, be healthy and whole, and then scale the work. Next slide. Our guiding principles are really focused around being with, and this idea comes from Circle of Security parenting around sitting with each other and being that open, strong, positive, nurturing force for each other and for our families. We work closely with Vital Village out of Boston, and this is Dr. Renee Boynton-Jarrett and Rhonda Alexander, in order to protect and defend and heal the dignity that's inherent in everyone. Our focus is on soul care for our patients and our staff, and as I had mentioned, reflective supervision. Next slide. So this is an example of our soul care, our time with Toby. Toby is our infant child mental health specialist. You see her in the middle with the flowers. And I tell you, those infant child mental health specialists are incredible. And she has an ability to hold this amazing, diverse team. Next slide. Workforce development. So these are some of our residents that we're working with. We have so many different types of learners that want to be involved in the early relational health space. We have volunteers, intern, early career faculties. I'm really proud to say that we are working with graduate medical education to create racial affinity groups for our residents that are part of Bloom. We are trying to create curriculum for a Bloom elective as well as a Bloom residency pathway. And then scholarship is hugely important, both qualitative and qualitative research in the form of QI, but also IRB approved research studies where we're working with local birthing hospitals to really be able to think long-term about how clinics like Bloom are impacting health outcomes. Next slide. So to give you a sense of our timeline, because sometimes things seem to be moving so slow, and then when you look at it, you're like, wow, we really are making progress in this movement. We started to conceptualize Bloom shortly after the racial reckoning around George Floyd, and wanting to know how we as a health system can actually focus and be pro-Black in our work. It took about 3 years to really get buy-in from senior leadership within a large academic medical center. I'm proud to say that we opened our doors in July of 2023 after garnering philanthropy, mostly private philanthropy, in order to start Bloom. We very quickly realized that we had to expand Bloom. Within 3 months of being open, we had more patients than we had slots for, and so we very quickly hired a third pediatric provider and expanded our template so that now in a typical Bloom session, we have 16 to 18 families that we can service. We also realized that we were experiencing intense vicarious trauma as a clinical team and really exhausted. And so in December of 2023, we really implemented formally our reflective supervision with our early childhood mental health specialists. Our group visit started in January. We launched our IRB approved evaluation in February of 2024. We are starting our racial affinity groups in June of 2024, and then our second parenting dyadic groups, Joyful Black Parenting, are starting the summer of July of 2024. Next slide. Because there's always questions around evaluation, I do want to stress that we are using validated scientific methods to help us better understand racism in healthcare. We have a multi-tiered mixed method evaluation to really assess how successful Bloom is in achieving service delivery goals. What are the mental and physical health benefits for both parents and babies? And we want to be able to look at that relational piece, right? The parent caregiver engagement, satisfaction with pediatric care, and trust of the medical system. Next slide. I can share with you some of our qualitative research questions around what made you decide to come to Bloom? What do you think of the clinic? What's most important to you? Is it important to you that you trust your provider? Is love important to you? We don't talk about love that much. And so we wanted to do this qualitative evaluation about how important is it to you that you feel as if you are loved by your provider. Next slide. So far, this is some of the data that's come out of the qualitative research is I feel like I'm around my people. It's good to talk to our own race because they, the Bloom staff, know more about us, that families enjoy their appointment, that it's comforting, that should be that it isn't rushed, that they receive good information, that it's interactive, and that they like it way better here. Next slide. So all of this is to say we are learning a lot and we have plans to continue to grow. Next slide. Our notion is that we want to be able to create national Black baby equity collectives that have research and policy piece, have a care continuum piece, really focus on workforce development, as well as the wellness of our providers. Thank you so much, and I'm really happy to answer questions, and I'm going to pass it to the next speaker.
Thank you, Dana. That was amazing to hear. Amazing to hear all of your work in action there. And I've known Dana for a little while through the Nurture Connection Network, and it's just amazing to see it all in a slide representation. That's the first time I've seen that. So my name is Allison Logan. I am the CEO and founder of Logan Consulting and Company, and I'm the co-founder of CT359, which is Connecticut and children developmentally ready and thriving at the ages of 3, 5, and 9. I am also a lead consultant for the Connecticut Data Collaborative, where we're working on a 3-year Pritzker Children's Initiative Community Systems Grant. And so I'm leading that effort because of the work that was begun in Bridgeport, Connecticut. Some of you might have heard through other webinars through here, through other Build webinars, the Bridgeport Baby Bundle. And so I'm going to talk a little bit about that today. Next slide, please. So a little bit about Bridgeport, just to give you a context. When I began work in Bridgeport about 18 years ago, you can see the state of Connecticut right there, and looking at the opportunity index. So Bridgeport is surrounded by the richest counties in America. If you see, they call it the Gold Coast of Connecticut. So surrounding Bridgeport are the richest counties, actually in the state of Connecticut and also in the world. But many of the Bridgeport's young children live with limited resources in families facing intergenerational trauma and structural racism. There are about 148,000 people in Bridgeport and approximately 2,000 births a year in the city of Bridgeport. Next slide. So how did Prenatal to 3 become a focal point for the Bridgeport community? Bridgeport Prospers was a collective impact initiative under the Strive Together. And some of you might be familiar with the Strive Together network. There are several, I think there's about 70 communities across the country. We were one of 4 communities in the state of Connecticut that had a collective impact movement. And part of the terms of the collective impact movement is that you pull cross-sector community folks and community members and parents across the community, and you look at data, and you look at impact, and you look at you look at where can you make a difference, but not in one sector, across the sectors of the community. So our Birth to 3 Community Action Network started to collect data. And we collected data from Head Start. We didn't have a common measure at the age of 3 in the city of Bridgeport, or actually in our state as well. So we used the Head Start Creative Curriculum Gold Assessment as a proxy measure. And when we looked at that, we found that 75% of 3-year-olds entering Head Start did not reach age-expected milestones at the age of 3. 21% of mothers had no or inadequate prenatal care in the city, and 63 of the city's around 2,000 yearly births were Medicaid funded. So the pictures that are next to that are our 2 reports. So we spent an entire year doing a landscape analysis, and this landscape analysis included parents and looking at churches and looking at really community supports and what were the assets that were in Bridgeport and what was there already. So before we could actually plan with the community, we had to figure out what was going on within the community. So we had 2 reports. They're very long. I can put links to them later if you would like. And what we started to look at is that the earlier the investment, the greater the return. So we looked at the intersection of child development, at the intersection of neuroscience, and at the intersection of economics. And so we put a lot of our efforts within the prenatal to 3 systems approach in the city of Bridgeport. Next slide. So through our collective impact process, we created 7 core community strategies evolved to advance healthy births, responsive services and supports for parents, and on-target development for children measured at the age of 3. These strategies are adaptable by other communities because it's a framework, and we're aligned with the CCSP, Nurture Connection, and Early Relational Health Framework. And our first 3 strategies focused on the people. So we really made a huge effort to make this a community-driven effort. And so we looked at universal and targeted interventions, which I'll talk about in a minute, but authentic family and community engagement, just like we heard from the other speakers today, that was at the center. And so we did co-design with community. We paid our community members and parents as consultants to sit on all of our decision-making tables. We did not make a move without consulting with the parents. We had parents and community ambassadors out in the community, talking with families, collecting information. We did community baby showers. We really spent a huge amount of time really collecting and information from families and really partnering with families as leaders on this work. And also parent community providers, agencies, and government associate advocates and ambassadors created a prenatal to 3 movement across the city. So we had tons of events, we had billboards. So we created this movement where we had hundreds and hundreds of people coming together and really supporting early childhood brain development, early relational health, and really supporting prenatal to 3 within the community. Strategies 4 and 5 focused on the organizations and their practices. So we found a lot of organizations with a lot of programs. And so we looked at coordinated strength-based services. We looked at wellness navigators. Where were doulas in the communities? Community health workers, which we heard Dana talk about. Where were they in the communities? Were they in the community health centers? And then building capacity of the prenatal to 3 workforce. So where was the workforce? What did the workforce look like in the city? And then strategy 6 and 7 focused on accountability and investment. So data, what data, both outcome data and connection and coordination of data across the system in the city. And then also at the same time, we created a sustainable strategic investment framework. One of the things we heard when I first got to Bridgeport and said, things come to Bridgeport and they leave. And they're here for 3 years and they leave. And we figured out that a lot of things came to Bridgeport with grants. So grants are usually 3 to 5 years, and when the grant runs out, the program leaves. And so we were intentional on creating a sustainable strategic investment framework, which first started with philanthropy and for the initial investment, but then really looked at public-private partnership, state level funding, and also looking at organizations within the community actually taking over these programs and services within their own budgets. Next slide. So we created the Bridgeport Baby Bundle. And when you hear the word baby bundle, you hear about it's a bundle of services and supports. But when we did our first strategic plan and we did our first landscape analysis, what we noticed was there's a ton of services in Bridgeport. First of all, they were disconnected. They were working in their own silos. But there was nothing really universal. And those community supports actually served small numbers of families. So when we were looking at universal and targeted supports, we had to come up with a bundle because there's not one thing that we could put in a city that would actually help to advance children developmentally at the age of 3. So one of the supports that wasn't there was universal home visiting. So the home visiting was there, but only for small numbers of families. So right now it's called Family Bridges, and after 6 years, it finally started and began last year. And it is partnering the Family Connects model with a community health worker. And this is a unique strategy with Family Connects in that not only are they getting universal home visiting after birth, they're also connecting with a community health worker. We looked at a pediatric bundle as well. So Reach Out and Read and Read to Grow and Sparkler and the Bridgeport Basics. So Reach Out and Read was in one community health care center, and we expanded it to 97% of the pediatric centers in Bridgeport. Read to Grow is a Connecticut-based program which talks about reading with moms at the hospital, and they get their first books at the hospital, and they can get books every month for their child. Sparkler is an app that has ASQ. It's our first app-based ASQ support, and also parental supports. Early relational health supports, activities to do with your children. It connects you with an early childhood specialist, and families can fill out the ASQ and the ASQ SE and be connected to our 211 system in the state. And the Bridgeport Basics. The Bridgeport Basics comes out of Boston, the Boston Basics, which are very unique videos that really foster early relational health, singing with your child, reading with your child. And we put these in all of the pediatric clinics across the city, as well as many community partners were sharing these videos as well with families. We increased doulas and community health workers across the city, and we actually lodged our doulas within our community healthcare centers for the first time and worked really with the OB providers and worked really closely to make sure we're advancing those throughout the city. And then we had music together classes across the city and infant toddler classes. And then we coordinated the targeted home visiting programs that were there because they were all disjointed. And then we increased home-based infant and toddler care across the city. So that was our bundle of universal targeted and supports. However, we didn't do that alone. We did that with partnering with the community. So we had community messengers who co-designed this whole thing through we worked on a community engagement spectrum. So we were really looking to shift power to the community. Community was paid as consultants to sit on all of our decision-making tables. And we have parent ambassadors that sit on our decision-making tables too. So that right now in Bridgeport, there's about 30 parents, consultants, and parent ambassadors that sit on our decision-making tables and also sit on other decision-making tables within the healthcare center within the city of Bridgeport. So we had over and still have over 30 community partners involved. We had community baby showers, screenings of the documentary Resilience to really look at adverse childhood experiences and building positive childhood experiences through the universal and targeted supports. Doula advocacy events. We had Mocha Milkshake Mondays where we talked about breastfeeding. So we had doula advocacy events across the city. And then at community advocacy training, we had several community members going up to talk about legislation when we were passing legislation within the state. So what's next? The Pritzker Children's Initiative has invested for the next 3 years on a community systems grant, taking what we learned in Bridgeport and really look at how can we create a Connecticut baby bundle based upon the work in Bridgeport. So this is where CT359 was created, looking at on target and thriving at the ages of 3, 5, and 9. And so we uncovered that working within the community, we uncovered some policy and data barriers that could not be resolved at the local level. So CT359 is a network of members who employ data, public education, and information sharing to help make sound policy and resource decision. So we're tackling these barriers, and hopefully this will lead to spread of the baby bundle framework across the state. Next slide. So what does transformational change look like in Connecticut? So we're focusing on pregnancy and the birth experiences, access to trusted caregivers, doulas, and community health workers. We're very fortunate that Connecticut is very far in Medicaid reimbursement for community health workers and doulas. Thanks to Doulas for CT, which was started by one of our doulas from Bridgeport, which is a state level advocacy group for doulas. And they're working on plans for Medicaid reimbursement for doulas within the community healthcare centers, and a Medicaid maternity bundle, which includes doulas as well. Participation of universal home visiting at birth. It is the state's intention that that will be universal across the state of Connecticut. Bridgeport is the first pilot site. However, there will be another pilot site happening this year, and they're looking at financing strategies and Medicaid and private insurance reimbursement to make sure that goes across the state. And perinatal supports for maternal health and mental health. We are focusing on child-adult early relational health. So bringing nurture connection movement to Connecticut and looking at the universal light touch natural supports that we had through our baby bundle portfolio, like Sparkler. Sparkler is now free for everybody in the state of Connecticut. So we're looking how to advance that within healthcare clinics. The Connecticut Basics, looking at early literacy supports like Reach Out and Read, Read to Grow. Right now, there's legislation for Medicaid reimbursement for Reach Out and Read. So we're looking at how to increase that across the state of Connecticut. And then focusing on positive parent pediatrician partnerships. So making sense of developmental screening within the community healthcare centers and referrals and services. And then promoting family centers, strength-based early relational health pediatric practices. Next slide. I'm not going to go, there's a lot of text on this slide, but this is in one slide, what we're looking at as the whole system. So looking at universal education and awareness, creating a maternity bundle, a hospital bundle, and then a pediatric bundle throughout the states. There are bits and pieces that the state already has, but we're looking at really bolstering up what those have. We have opportunities for training through the Community Healthcare Association of Connecticut. We have a really strong collaboration. So we're looking at doing early relational health training. Also, we have a new opportunity for Rapid EC, which is a community survey and parent and family survey, which is out of Stanford University. We will be launching this month our first Rapid EC survey with over 18 communities. And in the summer, we will do a Rapid EC survey specifically focused on early relational health and how parents are working with their pediatricians and what they're seeing and what they feel about child development. So we're going to do in the summer a Rapid EC effort around that. And so then we're looking at universal screenings in early childhood for child and parents, the childhood screening, developmental screening, looking at maternal and family screening, and then providing through our 211 network a portfolio of services. So we're looking at tracking the short-term ROIs on savings during early childhood and tracking long-term outcomes. So this is our panacea, this is our hope, and it will take us a while to get there, but we're taking all of the lessons learned and making sure that we're putting families at the center and making sure that whatever community that this goes to, that it really comes from the community and it's really developed with the community at the center. Thank you very much. I'll turn it back to David.
Take myself off mute. Okay, let's put the slide set down. Wasn't that amazing? And what we brought to you is early relational health in action and network impacts that are arising as a result of gathering this equity-focused, relationally centric focused effort and the collective effort across partners to really create change. You know, you've heard the importance of our family leadership and co-development with us. You've heard of some of the place-based approaches, which have been, we're organizingly, intentionally bringing parents in the lead and multiple partners in a collective impact, alignment, focused intentionally about that baby bundle around the earliest experiences. You've heard about practice transformation and workforce transformation that becomes relationally centric, becomes equity focused, and becomes mindful of the well-being of the carers themselves, not just families, but the carer and the system. And we have around us also a growing research agenda with partners and colleagues with Reach Out and Read, and also at Columbia University that are building a national relational health network of researchers. And then, of course, policy is central and core to all of this good work. I did not specifically go into that, but on our website, you can see our early relational health policy agenda, which is touches many aspects of family well-being, community well-being, workforce development, infant early childhood mental health advancement, and equity. And then, of course, the importance of spread and scale of the messages. So we bring to you this network approach, this of what we're learning along this journey, and we're eager to hear from you in our dialogue period here just in a moment. But I want to bring my friends a few questions so they can reflect with you a little further about their experience of this work. And the first question I want to bring is, why is the Nurture Connection work so important to you? And how did you come to it? So Dana, can I come to you first, and then I'll go.
So the early relational health work is so important to me because I see babies every single day in clinic. I see babies, I see their caregivers, and I know that it is that love, it is that nurturing, it is that strong connection that enables both the caregiver and the child to flourish, to get through the wonderful times and the hard times. I see it in my own life. I have 3 children and have very strong relationships and connections. And it's also something I recognize that isn't typically part of resident curriculum, isn't part of medical school curriculum. But it creates safety and it creates trust, and it enables us all to heal. And I wanted to be able to create a clinic that was wholeheartedly focused on the love and the trust, and be able to lift up the impact and say, this matters, right? This matters in pediatrics, that we can create safety, that despite immense amounts of adversity, particularly in populations of color, there's such a strong sense of belonging, a strong sense of community, and so much strength. That's why it's important to me.
Wonderful. Claudia, what do you find important about this work? How did you come to us?
Well, I came to this amazing work through the connection with Reach Out and Read, which is a program that is dear to my heart. And I have experienced Reach Out and Read at a professional level, but before the professional level, it was at a personal level. As a new immigrant mom coming to New York to receive services at Bellevue, as an adolescent parent who needed a lot of support, and whose first book for Alejandro came from a Reach Out and Read provider here in the clinic, who told me that as part of every visit, they would give me a brand new book, and how important that was. Before I got that book, I was already talking to my baby and singing and reading with him, but having that support and seeing the doctor taking the time to talk to me about not only the physical development of the baby, but really how important it is to have those moments of connection was striking to me as a new mom and as a young mom. And it has been wonderful to come full circle and now be in this unique opportunity to be able to give back to the same place that gave so much to me, and have the privilege of talking to these families on an everyday basis and learn so much from them, and really be able to have them now see themselves as ambassadors to the work that they were doing here, because what they learning here and the support they're getting from every person they encounter in the clinic, then they go into their own communities. In my conversation with them, they had not noticed that. And when I asked them, for example, have you shared what you have learned about the importance of early relational help with other people that you know? And all of them say yes. And I said, why? And they would say, because I have seen the difference it has made in my relationship with my children, with my family members, and how they compare notes between children, their older children, and now the younger children, that they have added all of this, extra moments of connection. And when they say, I tell my neighbors, I tell the people in my church, I tell the people in the community. And when I said, do you notice that you have become an ambassador? And that word ambassador meant a lot to them. And I could see the smile on this mom's faces, and saying, really? Oh my God, I didn't notice that. And that how what they are sharing with their peers and their families in the communities is helping, as Dana was saying, it's part of the healing process. I like to think of this work as healing, not only for the children, but all of those of us who are involved in the work, because we heal that inner child and we're healing generations. And as I like to tell the parents that I work with, do you realize also that you're helping form what kind of a human being you're sending out into the world, what kind of a parent, what kind of a husband or wife, that by creating this love environment, you're really dictating so many other aspects of your child's future. And that's something that usually they haven't stopped to think about and that they're happy to see. So it's something that is really dear to my heart and that I'm very proud and honored to be involved with.
Claudia, that's beautiful. And you and so many of the ambassadors carrying the message of this work is the infectious nature of this movement building effort, because people can feel it and see themselves and carry the message ever further. Allison, how about you? What brings you to, what is most important to you about this work, and how did you come to it?
Well, I came through a unique door. So I started my career as an opera singer, and I was a musician, and I went for undergrad for music education. And when I came out of school, I started music together classes. So I'm a music together trainer, and I had infant toddler classes, and seeing parents and dads and grandmas and titis and aunties bonding with their children over music was so fundamental in the trajectory of my work and like how I came to this work. So I studied, my master's was in early childhood brain development and how the arts specifically nurtures that. And so then I began working in Bridgeport, working in the school system, working with pre-K classrooms and teachers, and how the arts can really enhance all of that relational health between teachers and their students. And also we had parents come in and we were doing all of the arts activities with the kids. So I've always been in that space of how relationships, but I did it through the arts. And when I started the work at Bridgeport Prospers, we had music together classes, infant toddler classes across the city. And I said, how can we even expand this more? And, it can happen everywhere. This early relational health can happen everywhere, places that you least expected. And so it was my intent to make sure that cross-sector, across the whole community, that we were really promoting relationship building, and we were promoting early relational health within the parent and family, but also within each other, within the collective that we built with the parents and with community all together.
Phenomenal. So I'm seeing some questions coming into the chat. I'm going to come to those in a little bit, and I welcome all of you listening in to add questions, or we can open up the conversation. But I want to ask my dear friends, what's the greatest challenge that you faced in this work? How would you want to describe that? Allison, you want to start?
Sure, I'll start. One of the greatest challenges, I think, was keeping momentum. So we know change does not happen in 1 year. So we didn't start this in 2016, and in 2017, everything was built. It really, literally, universal home visiting literally just started this past year. So that's a long trajectory. And for keeping the momentum of families and parents and community, and right in the middle of COVID is when we started all of the stuff in the community healthcare centers, the expansion of Reach Out and Read, our doulas in the community healthcare centers. And then it was, those community healthcare centers, shut down. We had to rebuild momentum. So I think it's keeping the community energized continuously, keeping momentum of your community partners, and really making sure that your that community remains at the center. And we had to actually flip-flop our whole budget, because we said we're putting our majority of our budget to pay community to be part of this work. And so, that was another challenge, is making sure that, we were walking the walk that we said we were going to walk, and making sure that that was consistent all the way through.
Excellent. Dana, I think you were going to comment. What's been your greatest challenge?
So the greatest challenge to movement making is system change. For me, it's been a thoughtful and slow process, and systems are inherently built to maintain themselves. When I initially started to focus on early relational health in an anti-racist framework that promoted and lifted up families who were most crucially impacted by structural inequities, there was pushback from the system such that these services should be offered to all families. And of course, that's the case. Of course, we want every single child to flourish. And there are some children who have more structural inequities placed in front of them than other children. And being able to, in an evidence-based and community-engaged fashion, move a system to understand that Black and Brown children have worse health outcomes across the board, and our singularity of focus to improve outcomes for those most impacted actually influences the health of the entire population. That was my biggest challenge, and I feel like we still live in systems that some folks are privileged and others are very under-resourced. The second challenge is around sustainability and scale, that oftentimes these efforts, and this is, Allison, you brought this up, they are not baked into systems operationally and are funded through the generosity of private foundations, philanthropists. And how do we actually embed the work of equity to be the job of systems is, I think, a challenge that we all face.
Such strong points, Dana. Claudia, how about you? What's the greatest challenge you faced?
Well, I will speak specifically about the greatest challenge I'm seeing here with the community I serve. And we're seeing a lot of the new migrant community that we're seeing in New York. And how do you promote this type of work when the families have such huge needs and very concrete needs? And then on top of that, the staff feels like that's the priority in the moment, right? But how do we then sell this idea and help them see the importance that this is not something on the side, but how this can be so important and critical for the families, just as they're trying to also help serve some of the more concrete needs that these families are seeing in terms of housing and food insecurity and the trauma that they carry from their journey of trying to get to the United States through very traumatic experiences. And one of the ways we've been addressing that in terms of our conversation with families is how it's helping them see how a lot of things are out of their control. But this is one thing that is within their control. The way that they connect with their children, the things that they do on a daily basis, in the face of all this unsurmountable amounts of difficulties that they're facing. And the reason why they're here and they made that huge sacrifice was to provide a different set of opportunities for their children. And highlighting them and elevating these families and the power that they hold in their hands to be able to do something different and beautiful for their kids, because that's why they decided to come to the States. But I agree that sustainability and systematic changes are huge challenges, and I'm glad that Allison and Dana were able to highlight those as well.
Exactly. Let's go to some of the questions in the chat, and then I want to open it up even broader. But Cynthia asks, I think this goes to you, Allison, about the 211 network connected to Help Me Grow and how that works. Can you just talk about that a bit?
Sure. So as some of you might know, Help Me Grow actually started in Connecticut, and we do have a Help Me Grow network here in Connecticut, and our 211 system, it is connected. So our Help Me Grow system is connected. However, one of the things that we're trying to do here is it's got underfunded every year. So the Help Me Grow keeps getting underfunded. So we're looking to really advance Help Me Grow and really build the Help Me Grow system here. So it's not as strong as it could be, but the Help Me Grow system here is the connector, right? It is the connector for families. And so really for referrals. So we're really trying to build that effort. Our 211 system is housed at a United Way, and they are very underfunded and under-resourced. And so you have a lot of care coordinators who are way over, have way too many families that they're trying to coordinate for. So we're really looking to build up the resources for Help Me Grow in 211, but they are connected.
Wonderful. And Dana, do you want to mention Find Connect? And because it's of a similar ilk, right?
Thank you so much for the opportunity. So Find Connect, it is a mobile-friendly platform that allows for easy and efficient referrals to community-based resources and navigation with a case management platform. We have been using Find Connect as a clinical tool within our federally qualified health center since 2016. There actually are a bunch of Help Me Grow sites, most of them based out of Texas, that also use Find Connect. And it's very similar to 211, except for it allows for personalized action plans and a tailored way for navigators, community health workers to then follow up with families.
Excellent, excellent. I see a question in the chat that asks about how parents are recruited as consultants and how are the efforts to bring parent consultants that actually represent the families and the communities they serve. Maybe each of you might comment on that. Claudia, can I come to you first?
Sure. So each of the groups that you saw that are represented in the FNC, I mean, it was intentional. It was intentional in the sense of making sure that geographically, it was spread out throughout the country, and that we were looking at the different sectors of parents so that we can take into account their unique voices and experiences. And in terms of, for example, my work here with the families, I'm, for example, located in Manhattan, but my parents are coming from all over New York. And bringing very, in many ways, similar experiences, but also different experiences. So even within the immigrant community, you have families who have come to the States in very different manners and ways, with different levels of education. So we have a very diverse group of parents who have very diverse opinions about what matters to them and to their children. And I think that what makes the work so enriching is be able to hear what they have to offer to the work that we're doing, to inform everything that we do. And I know that for each of the parent leaders in the FNC is a very similar structure.
Excellent. Allison, how do you go about recruiting family?
When I first started at Bridgeport Prospers, which actually was backboned by the United Way, there was a group of folks called the community messengers, but it was very unidirectional. So they would go out into the community and provide information to the community. So we made a huge effort and put a lot of resources into really changing that into a really bi-directional process with the families. And so they actually went out and surveyed families and recruited families with young children, recruited parents with young children when we were doing this work to sit on our decision-making tables. And so it really is, it was a recruitment process during our initial landscape analysis. So we recruited a lot of parents with families, and we met on a regular basis. We had community conversations where we recruited more families. And when we started training those, they actually trained themselves. So the parents actually created their own training for the parents, and they actually created it themselves. They said, what do they want to share in the community? What needs to come back from the community? What data do we want to know from the community? So they actually structured themselves. And so they turned it into this consultant model, in which, we pay $30 an hour for them instead of, they wanted to get away from the gift cards, which was how it was. And so, paying them to sit on decision-making tables. And they actually did some self-training to do that. So it was a long process. We had to change from just listening to parents during focus groups to how do you really co-design something with parents where you're actually shifting and the parents actually have the power. We actually had to train healthcare, because when they sat on those tables, they weren't, their voices were not heard respectfully, and their voice wasn't heard, and they ended up, not. So we actually went and trained the hospital providers. We trained our community health center providers on really how to have parent voice really be at the center. And so that was a training process that they put together themselves. That they actually created the training that went to the community healthcare centers, that went to the hospital. So, it was a long process, and it didn't happen overnight.
Yeah, amazing. And Dana, how would you discuss parent consultants and their role in recruitment, representing your community, et cetera?
I'm hoping that the audience hears the commonalities across our different disciplines and, quite frankly, across geographies amongst the three of us. Because there's so many similarities. And we have what we call a FAB, which is a Family Accountability Board. The way that we recruited members for our Family Accountability Board is that they are families, patients within our federally qualified health center. We went through a process whereby our community health workers helped to recruit families. They were given information. They were asked to join. There was a very simple application, which was basically their name and then why do you want to join? We now have a lead who is remarkable. And this lead and her team, they are funneling different aspects of what happens in primary care through them. And so one of the things that they're working on is, how are we actually speaking about relationships, child development, and behavior with families. How are we actually training, in this sense, in an academic medical setting? How are we training residents to talk about behavior development and relationships? It often is a part of resident education that we don't hone in on enough. And so they are reviewing the curriculum that the residents learn, and they've decided, no, this isn't what we want to hear as parents. And they made their own videos. They made their own videos for how they want the residents to be taught about breastfeeding, around co-sleeping, around developmental milestones. And then those parent videos are then going to be taught to the residents instead of the existing curriculum. Our parent leads, they also are part of the conversations around how Bloom Clinic is functioning. They read through our IRB. They are part of the research methodology and the research meetings. And one of the principal investigators for the Bloom study was interested in using a validated tool. And that validated tool was looking at differentiations and variations of skin color in the Black community and how that relates to health outcomes. Our family lead was like, I understand this is a validated tool, but this is threatening. This is unsafe. We are not going to pilot this in clinic. It's not part of our evaluation. And so they are instrumental in shaping everything that we do. We also ran through the consent with our family members. And interestingly, all of the family members who we ran through the consent and the enrollment process said, I wish I could sign up for this study, which is pretty much unheard of. Across the board, you hear folks like from the NIH talk about the challenges of recruiting minority populations. And because we have a family board that reflects the diversity of our clinic, that hasn't been our experience. And essentially 100% of families now approached about the study now enroll. We also compensate them adequately, as you were saying, Allison. So they are experts and they are paid for their time. And that's a huge component of what we do.
Amazing. The theme of dignity, trust, partnering, relational centering, and honoring the strengths of all comes through as core values, of course, in all this important relational health work, and the guidance that families help us look at all things we do critically, and then ask the harder questions about systems change in order to be able to do so. One thought, I do note a question that was raised about how do we translate some of this into the early care and education space? And I'm wondering, each of you, how you would comment on that. Allison, maybe you first.
Sure. It's interesting because in the state of Connecticut, the two spaces are a little bit polar ends, and then you have your early care and education space, but we're really trying hard to bring the medical community with early care and education. And one of the links we have here is Sparkler. So Sparkler app that has the ages and stages and parental support, that was started in early care and education, and families they train teachers to do it with their families, and the families use it at home. And so it started in early care and education, and now we're seeing how it can move into the medical community and the pediatric sector, and what does that look like? And so we're starting to have some really good conversations about how that can come together. And I think early care and education, we created here in Connecticut a blue ribbon report. It was from the governor commissioned a blue ribbon report talking about restructuring early care and education. And a piece of it is the relationship between, caregiver, which is teacher and children, and then the relationship between children and parents is part of that early care and education. So we're pretty lucky that those conversations are really starting here and starting to cross-pollinate here.
Amazing. Dana or Claudia, any comments about ECE, early care and education guidance?
Well, I can speak from the perspective because I think Reach Out and Read is a wonderful example of that. How we're taking advantage of the infrastructure of the medical system, that we're meeting the families where they're at. They come to the doctor. They have to come for their vaccines, right? Before the children even start school, they're coming to their regular checkups, and taking advantage also that the majority of the parents see the doctor and the medical professionals as trusted messengers, and in being able to help the doctors realize the important role they have in sharing these messages with the families, right? That it's not just the physical development of the child, but the social emotional development. And that happens within the context of the arms of the caregivers and the parents who are holding those babies. And that a book is just a tool, right? So a book is providing every regular checkup, but that is just a tool that can be used for talking to the baby and connecting and creating those magical moments that have such a long-lasting impact in that baby's life before they hit the school center. And that the first, if you want to call it like that, educator, the first teacher is really that caregiver. And that the best learning happens within the context of love.
We talk about the relational foundations of literacy, and Reach Out and Read has adopted that sense of making visible that those earliest of relationships of caring, joy, celebration, nurturing are the foundations for not only health, but also early literacy too. Dana, you were going to say something?
The connections that we have with community, particularly in the educational space, run pretty deep for us. And so one of the great partnerships we have, many of you might have heard of an initiative called Oakland Promise. It started in about 2016, and now several other communities also have promises. And so the Promise is a cradle to career initiative that supports the educational success of a child. And we not only were the evaluators for the pediatric baby component called Brilliant Baby, but we also enroll families directly into this program called Brilliant Baby, which is housed in the Oakland Educational Fund. The notion of Brilliant Baby is that we talk about educational attainment and outcomes, really shifting hopes to expectation of college-bound futures for our infants so that it can help to catapult generations of children out of poverty by establishing 529 accounts for babies funded by the city of Oakland and philanthropy before the first 3 years of life. And then we also are pairing parents with financial coaching and the educational system and tracking those babies to actually ensure that they not only have access to their educational funds, but that they are supported from infancy through the school age and then into college. It's a really novel program, and it's actually pretty wonderful as a pediatrician to be able to walk into the room and say, I care about your baby, I love your baby, and I'm going to help your baby get to college. The other way that we're working with early education is that we have our community health workers, and our community health workers, one of their largest tasks is helping with childcare and activities, helping families enroll in programs like Head Start and finding playgroups.
Amazing. Our time is amazingly coming to a quick close, but I want to give each of our panelists just like one moment to imagine where this work will be in 5 years. And Allison, what would you say to them? Where would you imagine we're going to be in 5 years of this Nurture Connection movement?
I think in 5 years, the conversation is going to shift from like putting all the pieces together, and that you're looking across system and this shows up everywhere. I'm that's what I'm really hoping, and I'm already seeing it in the state of Connecticut. So I'm hoping that when we're having this conversation in 5 years, we're talking about how to expand it, not how to bring it. And I think, the conversations that we're having and these conversations are so important to spread the message and for parents to really spread the message, just like what Claudia is doing, and parents are talking about it and are ambassadors for it. And I think, this conversation, first of all, every time I talk about ERH or every time I talk about Nurture Connection, people get so excited, and I think, it's something that, that families can really wrap their arms around and understand, like, this, everybody needs this type of level of support. So I'm hoping in 5 years that this is we're not introducing it, that we're talking about it in all places.
Claudia, for you?
Absolutely. That would be the dream come true, right? That not people don't stop to say, what? Early what? But they say, of course, and they see the value, and that actually we're missing out by not investing more in this, as Allison, and Dana were saying. And it's just like, this is, if we want to really be able to make a huge impact, we have to be investing in this type of work, because it's where we see the most return. And if we want to think about the future of our children and the generation, that's where it starts. So we got to put our money where our word has been, right? And really walk the walk, and not only say it, but get everybody to get involved at the level of sustain this type of work, and seeing that everybody has a role in making sure that this type of work continues to advance in whatever work line you have. It doesn't matter what type of profession you have, that we all are able to share this sort of experience, because even if you don't have children yourself, people who do, people who have access to families, and we all have to be equally invested in making sure that this becomes the norm and not the exception.
Wonderful. And Dana, last thought?
My goals for 5 years is that we truly see scale and sustainability of health sector transformations within health systems to focus on 0 to 3-year-olds in clinical practice. I would love to see blooms across the country.
That's phenomenal. And my goal for 5 years is that we have demonstrated this relational health nurturing focus yields flourishing of children. That's measurable and demonstrable, and that inspires the movement across all communities and policy changes to support it. So thank you all. Thanks, Bill, for allowing us to share our work with you. Join our Nurture Connection network. You can go online, sign up for the newsletter, and we welcome further conversations. Thanks so much.
Thank you.
Hey, everybody, going to take just a quick minute to give a shout out for the Prenatal to 3 Capacity Building Hub Exchange. You will find others of like mind and experts and resources and 27 other members who would love to engage in conversations with you. So please join up if you haven't already. I want to say a special thanks to our panel, Claudia, David, Dana, Allison. You all were fantastic. I learned a lot, and I'm sure that the participants did as well. Thank you all for attending today. We really appreciate you taking some time out of your very busy days to be with us. So thank you, and we'll see you next time.